Awareness of inequities in the healthcare system is not a new topic. For as long as there has been racial injustice in this country, there have been serious inequities in the ways in which people of color, African Americans, Native Americans, Hispanic Americans have been treated. One of the strongest voices for dynamic social and economic change in this country has been Wes Moore, the CEO of Robin Hood Foundation, a New York City powerhouse that has for over 30 years been finding and funding scalable solutions to lift families out of poverty. We're honored to share a conversation between Wes Moore, the CEO of Robin Hood, and Jean Ackias, Senior Vice President, AARP Global Thought Leadership.
How are you today, Wes?
I am doing so well, Gene. This is beyond an honor. I'm so humbled to be able to join you on this virtual stage. Humbled to see everybody, and thank y'all for logging in, because when I think about my journey, I come from I am the descendants of activists and teachers and ministers and truth tellers and storytellers. My grandfather actually was the first one in my family was actually born in the United States. He was born down in Charleston, South Carolina. And actually it was the Ku Klux Klan that ran him and my great-grandparents out of this country. And the majority of my family made a pledge to never come back to the United States. But my grandfather made a different pledge. He always pledged to come back. He felt that this was the country of his birth, that this was the country that he was a proud birth citizen of. And so he eventually came back to the United States, went on to go to school at Lincoln University, a proud HBCU over in Pennsylvania, and eventually became the first Black minister in the history of the Dutch Reformed Church. The church that was actually the official church of apartheid South Africa. And I think very much about who I am, and I didn't realize until I got older, was very much born through the DNA that came through my family. My grandmother, who was actually born in Cuba and became a school teacher in the South Bronx for 29 years. My mother, who in her 20s became unexpectedly and in many ways unprepared, became a widow with 3 children that she was going to raise on her own. This is a woman who pushed and sacrificed. And so I think so much of who I am come from them. We moved from Maryland up to New York after my father died when I was young. And some of the biggest challenges and difficulties I had and adjustments I had was when I actually moved up to New York, moved up to the Bronx to go live with my grandparents. And I noticed that as I was going through this transition, eventually was sent to military school, eventually through a lot of second chances and a lot of opportunities and a lot of people, frankly, just seeing something in me before I was ready to even see it in myself, I now received this Rhodes Scholarship as I was finishing up college.
Well, thank you so much, Wes. There's a couple of points in the book where I personally had to put the book down and to kind of reflect even on my own personal journey. So I just want to thank you just for how candid you were about talking about your own journey, moving from Baltimore to the Bronx, and what did all that mean to you personally, and also kind of thinking about how where you live matters in many ways.
I know that I was raised in a community that was chronically neglected. And I knew it by the air that we were asked to breathe. I knew it from the water we were asked to drink. I knew it from the schools we were asked to attend. I knew it from the homes we were asked to live in. I knew it from the way that our community was policed. I knew it from every single dimension, because everything around us is screaming at you that something is different for you. And so how we think about our environments, we can't just pretend, we can't do a Pontius Pilate where we're just washing our hands of responsibility and say, well, I mean, look at how they grew up, or look at who their parents were, or look at that neighborhood. Because what we're doing as a society, if we don't realize it, we're washing our hands of responsibility because somehow it makes us sleep better at night. And what it's doing is it's embedding our own complicity in this. We cannot embed our own complicity. We have to challenge it.
Along those same lines, Wes, when we look at Baltimore and we look at zip code, and we think about life expectancy and the opportunity to be able to live a longer and healthier life. When you look at Baltimore, life expectancy in Sandtown is about 70 years. And only a few miles away in Rolling Park is about 84. What can we do to ensure that people of color, communities of color, and those with low incomes have the opportunity to live a longer and healthier life?
It's staggering, because when you're looking at the difference between the Sandtown and a Roland Park, you're literally talking less than 2 miles. And we can't act like that's unintentional.
In the book, you say, my father was dead 5 hours after having been released from the hospital with the simple instruction to get some sleep. The same hospital was now preparing to send his body to the morgue. My father had entered the hospital seeking help, but his face was unshaven, his clothes disheveled, his name unfamiliar, his address not in an affluent area. The hospital looked at him askance, insulted him with ridiculous questions, and basically told him to fend for himself.
And I still can't shake the feeling that I was robbed. And I was robbed for the fact that there were people who, when they saw him, they saw something less than. Mm-hmm. I think about it in context of the world that we live in now, where we watch these daily reminders of this, it's a lack of appreciation of humanity in people. It's a lack of appreciation of a basic dignity. When he went to the hospital, he was looking for help because he didn't know what was going on. He wasn't asking for judgment. And I think that how we think about this in respect to right now, he wasn't asking for people to question whether or not he had insurance. He was looking for help. A human being asking another human being for help. I think about this even in respect to how this moment has changed, changed the way that I very much look at this world, and it's partially because we have to appreciate the fact that we had so many of these challenges and these dynamics that took place well before COVID-19. We have to rebuild better. We have to rebuild with an idea that there are certain things that we just cannot as a society accept anymore. We can't accept an idea that we can have someone who is working a full day's work and still living in poverty. We can't accept the idea that we have tens of millions of people in this country prior to COVID-19 who don't have health insurance. And a singular incident is enough to knock them and their family and their entire trajectory off base. How then do we make sure that we are creating frameworks and supports for our large society so that these singular incidences, no matter how horrific and tragic they are not enough to determine what is going to be the destiny for many people who frankly aren't even to the point that they can even have a say? That's the type of society that we have to rebuild.
As you heard, Wes Moore's journey began in Baltimore, a city that has been challenged by the crushing realities of social, economic, and racial inequities. Nancy Brown, the CEO of American Heart Association and a member of C-TAC's board of directors, has been an outspoken proponent of equality and health equity. AHA's Baltimore region has taken that direction in an engaging, community-centric level, creating the American Heart Association Community Health in Action Task Force. Please welcome Ms. Nancy Brown.
Today, 50 million people in the United States are at higher risk for cardiovascular disease because they lack access to quality care, healthy food, education, employment, and housing. The combined effects of COVID-19 and a strained economy mean that issues of health equity and health outcomes are strikingly more prevalent. With under-resourced populations hardest hit, we have stepped up our focus to convene stakeholders, patients, and community organizations to break down barriers to health through research, quality of care, our health improvement programs, advocacy, and community initiatives. As an example, we're extremely grateful to have received a $1.7 million grant from the Bristol-Myers Squibb Foundation to improve patient outcomes across the continuum in Baltimore, Maryland. This is just one way we're investing millions of dollars in social entrepreneurs and community-inspired solutions to improve health equity. We're so proud of the exceptional leadership of our local board members, Dr. Athal Morgan and Dr. William Ashley, as well as the work of our staff team and the Community Health and Action Task Force, including Rhonda Ford Chapman, Amanda Pyle, and Jalissa Powell. Eliminating barriers to care is a guiding value of the American Heart Association, and we have championed this work for nearly a century. It is an essential foundation to our mission as a relentless force for a world of longer, healthier lives.
My name is Rhonda Chapman, and I am the Vice President for Health Strategies for the Greater Baltimore region of the American Heart Association. What we were finding, and what is known across the country, is that many under-resourced patients weren't completing that journey and weren't getting the best health outcomes possible from the service of a specialty care provider. As we began the project, our charge was to convene a collective impact coalition representing all aspects of the system of care for stroke, AFib, and VTE patients. So it was incumbent of us to recruit patients, caregivers, community health workers, managed care organizations, and other professionals to make sure that we were addressing every step in the patient's journey. And what became very clear early on was that we had to look at those points in the journey where the social inequities in the city of Baltimore and across the country were impacting that patient's ability to access the best care possible.
My name is Jalissa Powell. I am the project manager for Community Health and Action run by the American Heart Association. It is my primary responsibility to engage community stakeholders and helping us to both develop, implement, and then think about how to sustain strategies to help patients navigate through the healthcare system. It was clear that we had a very complex issue that we wanted to tackle, but it is rare that folks across the continuum, including patients, are at the table to try to troubleshoot and brainstorm what that might look like. It looks different than had it just been specialty care providers sitting around the table talking to each other.
I am always very pleased with the response we get as we talk to our providers about what is the best possible resources that we can bring to bear to help our patients have the best outcomes. So everybody was well versed in our work and really excited about participating and joining together for the patient.
From the very beginning, all of our stakeholders were very candid and very engaged. And I think some of that is a testament to the relationship that all of those folks had with the American Heart Association. They trusted that we were bringing them together. It was a safe space for them to share. I think what has changed over time actually is that we've had to focus our conversations a little more about what can we accomplish. So the first few meetings, it was sort of trying to eat an elephant in a 2-hour time frame. And as time has gone by, we've found ways to focus. We are breaking it down to, in the next 90 days, what can we accomplish and what does that look like?
My name's Amanda Pyle. I work within the sector of American Heart Association that is called the Quality Outcomes Research and Analytics, also known as QUORA. I'm one of the healthcare QI business development managers, and that's a really great question. What we saw from the hospital perspective is that we knew here in Baltimore City that the hospitals were giving really great inpatient care. But because of prior successes that we had in Maryland working on a whole state level systems of care collaborative, specifically in the stroke systems of care and the STEMI and NSTEMI systems of care, we knew that we would have the most success and best patient outcomes if we put together a collaborative of those individuals within the hospital that touch patients that are affected with atrial fibrillation.
We are fortunate in Baltimore that beyond just the American Heart Association looking at social determinants of health, the city as a whole is looking at how do we really pay attention to the things that impact people's health that are not like clinical markers. So we find that housing is a big issue. If you don't have affordable or secure housing, your health outcomes are likely to be poorer than somebody who has those things. We found that transportation's an issue, just financial security in general. The health department said food insecurity is a big one for us, but also mental health resources are a challenge. So it allows us to, one, for me as I lead the task force, to bring that information to the task force and say, what do we know? Who do we know? What resources and interventions do we know that are already out there that could apply in this setting, that we could pilot maybe with one or two of the providers who sit on our task force, to figure out what works and then share that information.
I think there's always going to be challenges when you are bringing together a large amount of people for a large city. We're still going through a pandemic, and we have definitely seen how people's roles and responsibilities within the hospital change, how some programs are beefed up a bit, some programs lose resources or combined. So I think that that's always going to be a struggle. But what gives me hope at the end of the day with regards to the Community Health and Action Task Force is that the community, the hospitals, we all know that everybody is involved in this, and they do care about their community members, the hospital, the cardiologists, the nurses, they care about their patients. And so now we're not only just capturing the clinical side of things, but we're capturing these social determinants of health and the specialty care discharge information so that we can start understanding at a higher level what is going on with our AFib patients, with our stroke patients, and how can we help them after they leave the hospital so that they can continue to have healthy and happy lives.
Just as the Baltimore team has engaged the community in reaching out to elevate health equity for all citizens, we're working with 25 churches in the greater Oakland, California area to build a faith-based community advanced care navigation program that will help people that are dealing with advanced illness care and their precious caregivers. As you might imagine, in the time of COVID-19, those efforts could not be more important. I'll join you at the end of today's sessions for some final brief presentations and a preview of what the next 2 days will offer. Until then, I know you'll find the richness of information available within this virtual summit to be both useful and fulfilling. And we note with great appreciation that the generous support of our sponsors has made it possible for us to bring this virtual event together. Many of them have a presence in the virtual exhibit space on this site. Please, folks, take the time during the breaks and in free time to visit them. And as we do, thank them for their incredible support. We'll see you back here to wrap up with the final plenary session. I'm Cynthia Carter-Perelliot, wishing you health and continued dedication to those most in need of our support.